So it's my great pleasure now to introduce our next speaker, Dr. Lon Schneider, who comes to us from the University of Southern California, where he directs the Alzheimer's Disease Research and Clinical Center there. He is a senior scientific advisor for the NIMH, which is the National Institute of Mental Health, and he's on the advisor to the American Psychiatric Association, their Committee for Practice Guidelines in Alzheimer's and Other Dementias, and the Worldwide Federations of Societies of Biological Psychiatry Task Force on Dementia. He's also a leading expert on clinical trials, and so I will not eat into his time and hand over the podium to him.
Okay. Thanks, Frank, and especially thanks to Dan for being so eloquent in making all of my points, all of my practical points at least, and also for reminding me to say that the only place I would differ from him is that I don't need cartoons to offend all of you. I can pretty much do that by just saying good morning or talking to you about some facts. And this is going to be a data-driven presentation. I think Dan, though, set this up very effectively about the difficulties in treating behavioral problems in dementia. And if you'll notice the subtitle, does prescribing drugs for BPSD constitute elder abuse, assault with a deadly weapon, and racketeering under California law? This is a serious issue, and you'll see why a little bit later. I'm an academic, so I'm going to speak like an academic. I'm also going to disclose like some academics. You've got this written down there, so you can put down your Dostoevsky and read this rather quickly at your leisure. The main point you should simply take into account with my disclosures is consulting with pharmaceutical companies in the development of drugs for treating Alzheimer's disease, and then consulting with the California Department of Justice, et cetera. This presentation, I probably have about 10 minutes of disclaimers here, but this presentation speaks exclusively about off-label drugs, and anything I say about the drugs are off-label. They're not indicated reasons for using these drugs, and again, I've listed them. A main theme of this goes back to Galen, who is a Greek physician working in Rome in the second century. And he had an expression, all who drink of this remedy recover in a short time, except those whom it does not help, who all die. Therefore, it's obvious that my medicine fails only in incurable cases. This made him extraordinarily popular. People would come to him for treatment and would be able to rest assured that, you know, if they died or their loved one died, it was because they were destined to die. It wasn't because the treatment was ineffective. And he wrote this out on about 180 peer-reviewed papyri in different ways. But the graph below his portrait actually points out what we see in clinical practice and what we see in clinical trials. Generally, with patients, with people who we're treating, we see improvement over time, except for some. So the background to this is that as Dan said, the vast majority of people with Alzheimer's disease show agitation, delusions, aggression, and they suffer, and they cause great distress, and they especially distress others, which is something to keep in mind. Most patients with dementia are prescribed psychotropics at some time during the course of their illness, and this is presumably in a good attempt to treat their problems. Dan brought out some of the issues again, in some cases of purporting to treat a patient with Olanzapine and actually make them worse. Researchers and governments have cautioned that the drugs we're using may be both ineffective and dangerous, and as a logical outcome of that, we continue to use them, and it's quite remarkable. I'll add one case to the several mentioned before. An 80-year-old woman living at home with her daughter, ambulatory, no cardiovascular disease, has been diagnosed with MCI for about 4 years. She's progressively worsening. So what does the physician do? Puts her on Aricept, on Donepezil, 5 milligrams. 4 weeks later, she's agitated. She's not sleeping. She shows fitful sleeping. She's suspicious. She's dysphoric. So what does the physician do? Provides Risperdal, 1 milligram at night. 4 weeks later, hey, she is sleeping better. She's less agitated, but she's also apathetic, less interactive, tends to sit and not move around too much, has a slight tremor. 4 weeks after that, she fractures her hip, and it was downhill from there. Just keep the case in mind. Over the last decade or so, antipsychotic drugs in particular have been recognized as being quite hazardous. There's government oversight. Health and Human Services audited this. There's particular concern in nursing homes where 83% of antipsychotic prescriptions for nursing home residents were not for schizophrenia or for depression, but for mainly dementia. And the potential here, as you'll see in a moment, is quite significant. Dan again outlined ways of conceptualizing the myriad of behavioral symptoms that occur not just in Alzheimer's disease, but in dementia in general. And he was careful to point out the multifactorial nature of dementia. There are different ways to conceptualize the behaviors, but the point of this slide and the point I want to make is that they are really hard to group into a syndrome. You could talk about people being depressed with Alzheimer's disease. You can talk about a psychosis of Alzheimer's disease, as I will in a moment. But it's quite difficult to get your arm around individual symptoms or to identify them as part of a syndrome. A little bit later, Adam Boxer, Mario Mendez will talk about frontotemporal dementia and some behavioral syndromes and symptoms related to that. But it is quite difficult. If it's difficult to talk about individual symptoms, behavioral symptoms or syndromes, then it's also certainly difficult to try to target some of these symptoms for treatment. A bit of a digression now. This is kind of a mini timeline of geriatric psychopharmacologic progress with effectively modern geriatric psychopharmacology starting in the mid-20th century. I'm mentioning Premarin, which was desiccated equine estrogens, because as soon as that drug became available, it was used for a variety of psychotropic effects as well. It was quite early recognized as having psychotropic effects. But then Thorazine, chlorpromazine was marketed in 1952, and within no time, it was being advanced for treating, as you see there, the agitated senile. Imipramine, tofranil came out, Librium in 1963, and haloperidol in 1967. So from the beginning, there was both the active use of antipsychotics to try, in a good, well-meaning attempt to try to treat agitation in dementia, and there was the concern about their use. There hadn't been a clinical trial of antipsychotics for dementia until the very early 1980s. They were basically being advocated on the basis of case experience. just like Galen advocated his treatments. OBRA, but because of the concerns in 1987, OBRA 87 was legislated, and in 1991 regulated, and we started looking a little bit more carefully at the use of these medications. But after OBRA, Risperdal came on the market, other atypicals, and immediately experts, my colleagues, I suppose myself, agitated or advocated, depending on how you look at it, for the use of these drugs to treat behavioral problems in dementia. The atypicals were seen as being safer or different or more effective than the original antipsychotics. At the same time, the serotonin uptake inhibiting antidepressants came on the market, and those were seen as being safer than earlier antidepressants. And we know now that that's not at all clear. The first part of this century, though, had been characterized especially by a ferment in clinical trials, a good number of clinical trials of atypical antipsychotics, and almost at the same time, concern about adverse events in terms of cardiovascular adverse events and death. And this is sort of a bit of history. You can read that at your leisure. But at the same time, with this concern came investigations of pharmaceutical companies, of physicians, of the advocacy of these drugs being used off-label. And to digress for one moment, drugs are labeled for an indication because they show evidence of safety and efficacy. A reason why a drug would not be labeled by the FDA for an indication is because it shows no evidence of efficacy or adequate safety. So there's a reason why these drugs are not indicated for dementia. If you were reading yesterday's New England Journal, you would see this table identifying the largest pharmaceutical company criminal mostly settlements in the last few years, and I simply circled for you, you may or may not have this, that many of these drugs are the drugs that we use to treat patients with dementia. So this is a bit of a long way of saying that our treatment of behavioral problems with drugs in dementia is informed by, in effect, a metaphor, by us being highly rational and observing that psychiatric symptoms in dementia seem to be similar to psychiatric symptoms in depression, in schizophrenia, in anxiety, and other primary disorders, that there are drugs that are effective in those disorders, and that therefore the behavioral phenotype that we see in Alzheimer's disease should be responsive to these drugs. That symptoms in the elderly that appear similar to those that comprise valid symptoms in younger adults should respond into the same treatments. This is what informs us to give an antidepressant to a patient with depression and dementia, or an antipsychotic for somebody with delusions, or an anticonvulsant for aggression. It's not evidence-based, it's rational, we mean well by it, but this is how we've rationalized it. And I'll just show you some examples from 1956, from an ad in 1956 for Thorazine, 4 years after it was marketed. Doctor, what can you do for POP? And Thorazine here is advertised for the prompt control of the agitated, belligerent, senile. The recommendation to the physician is to carry ampules in your bag so that you've got them ready to use at a moment's notice. Another version of the ad for prompt control of senile agitation. There's a bit of a discussion in fine print under the tyrant in the house heading about the kinds of behaviors that Thorazine should be able to treat, and then a tagline that it's one of the fundamental drugs used in medicine. Now, that was 1956. Now we're 40 years later, and here is a Risperidone ad from 40 years later. Again, off-label, again, arguing that Risperidone could be particularly useful for treating patients with dementia. Hostile outside, fragile inside, and a discussion of the signs and symptoms that might be, that Risperidone will treat in patients with dementia, although they don't quite say dementia. This is fairly important because it was this kind of language, and also reminding you that it's the #1 prescribed drug in long-term care. Now it's not. Now Seroquel is the #1 prescribed drug. But in any event, this is important language because it tended to inform. I'm just putting up this visual to point out that nothing really changed over 40 years. It tended to inform proposed criteria for psychosis of AD because we were looking for pharmacologic treatments of patients with dementia and agitation and psychosis. And because FDA was reluctant to be able to label these drugs, mostly because of lack of evidence, what in part evolved was the concept of psychosis of Alzheimer's disease. The main reason for this is to be able to identify a clinical entity for, that might be treatable with antipsychotics. This entity was recognized by the FDA. It's still recognized by the FDA, but it helped to support some 16 different clinical trials of antipsychotics, placebo-controlled trials, to assess the degree to which Risperidone, Olanzapine, Quetiapine, Aripiprazole, and Haldol might be effective in treating symptomatology. Out of these 16 studies, though, came the following effects that I'll talk about. The one that you should, the two that you should simply jot down is that overall, these studies did not show efficacy for antipsychotics. One or two studies showed statistically significant effects, but they were quite small. The other thing you should jot down is that these studies as a group provided the evidence that antipsychotics were associated with death and that there was a considerable increase in deaths in patients prescribed antipsychotics. I'll skip this because of time, but this is just tracking antipsychotic use. I'll point out on this slide that you can look at in your handouts that when you look at individual nursing homes, there's a strange and unusual dispersion of, in terms of the frequency in which drugs, in this case antipsychotics, are being prescribed. Very widely variable from one nursing home to another, and it's too great a variation to account for differences in the patients in those nursing homes. But here is a summary of the evidence for efficacy of antipsychotics from these 16 or so clinical trials. For those of you not familiar with forest plots are a way of summarizing data where the point on the horizontal line is the effect, a 1-point, a 2-point effect, and the horizontal line itself is a 95% confidence interval. When that line crosses the 0 line, that means not significant. So you can let your eye run down this graphic. You don't have to read the names. You don't have to look at doses. What you can see is that in study after study, with a couple of exceptions, there was no particular efficacy for antipsychotics for treating psychotic symptoms in patients with dementia, both in nursing home patients and in outpatients. And this is what it looked like. This is what these studies look like a little more closely. What one sees is over 10 weeks or so of treatment with either drug or placebo, whether in this case it's olanzapine or whether it's risperidone, but it could just as easily, or aripiprazole, but it could just as easily be risperidone here, you see two remarkable facts. One is that overall people show improvement in symptoms, and quite substantial improvement in symptoms. This is more than a 50% improvement on this scale. And at the same time, there is very little difference between the use of placebo and the use of medication. I challenge you to tell me which one of these studies claimed statistical significance. But whether one study is statistically significant or not, you see that there's a very small effect. And this then can be translated to clinical practice. This is our clinical experience. We prescribe an antipsychotic, and many of our patients are quite remarkably better in 2 to 4 weeks and longer. Fact is, they were likely to be better no matter what we did, as long as we did an intervention. And this is our experience. This was Galen's experience. In 2006, NIH funded a set of studies to look at the effectiveness of atypical antipsychotics in outpatients. Long story short, we couldn't actually distinguish overall effectiveness differences between placebo and any of 3 antipsychotics. We could distinguish that there were more side effects with antipsychotics, and we could distinguish, as this slide would demonstrate, that in some measures on symptom scales, we would see that symptoms were somewhat more improved with the antipsychotics. But when this is weighed against side effects, it was really hard to come up with any advantages. The second point that I asked you to jot down from a previous slide was the risk for death. Some of my colleagues would ask an audience, oh, this is such a slight risk, and who here has seen a patient die from an antipsychotic use? Well, we don't necessarily see that, as you'll see in a moment, because of other intervening effects. But this is the evidence for increased risks for death. When we pooled together the 16 studies, when FDA pooled together the 16 studies, one sees a consistent trend for there to be 1 or 2 or 3 or 4 more deaths in the drug group overall. So that when these are added up, you see that there's an odds ratio of about 1.5, a relative risk of 1.6. And the effect of this is that 4% of patients will die on drug over 10 or 12 weeks, compared to 2% on placebo. Oh, well, a 2% difference, 4% versus 2% over 10 weeks. Well, that's not too bad, is it? Well, yes, it is. You multiply that out over the course of a year, and we're now up to somewhere of the order of a 10% risk difference. Or as Helen Kales has shown in VA outpatients. Now, we're not talking about nursing home patients, but outpatients. If you look in the lower, your lower right-hand corner, this is what we experience as clinicians in terms of death of dementia outpatients who are being treated with those following medications. That, for instance, Olanzapine, 27 out of 100 patients who are maintained on Olanzapine for about a year will die within that year. So what we're experiencing as clinicians is a very high death rate anyway, and then the antipsychotic use perhaps is not, to the degree that it increases this rate, is just not appreciated. There are other adverse events of antipsychotics as well. Dan mentioned a number of them. You can read this faster than I can describe it. One to focus on, though, is cognitive decline. As Dan pointed out, Olanzapine is particularly associated with cognitive impairment. And in fact, the magnitude of that effect in people with Alzheimer's disease who have only mild illness and no behavioral problems when treated with olanzapine or placebo, the effect in terms of the ADAS-Cog was twice as great as the effect of Aricept, but in the opposite direction. It more than overwhelmed that effect. The next thing in my last 5 minutes or so that I'll want to bring up is discontinuation. For whatever reason, we as clinicians are rather timid about discontinuing an antipsychotic. We tend to think that the antipsychotic is maintaining a patient and that discontinuing can be rather disruptive. In at least 3 trials now, that's not been shown to be the case. And in fact, it's been quite the opposite. This is a British trial, DART, for AD. The point I want to make on the left-hand side is that discontinuing the antipsychotic had no effect on behavior, had no effect on cognition. What it did have an effect on is on your right-hand side, and that is again on survival or on deaths. Patients who were continued on antipsychotics and not discontinued compared to those who were discontinued showed less survival. The magnitude of that is quite dramatic, but at the end of but if they were continued for about 36 months while their colleagues were discontinued, their survival was half that of their discontinued colleagues or patients. This is a big deal. This is a big effect, and we, of course, don't recognize it in our day-to-day clinical practice. We can't recognize it. I'll skip these clinical cases because of time. But this leads to a main point, and that is that I'm not the only one who might think that perhaps we should not be using these medications. The concern about this, the black box warning, has led others, including Medicare, CMS, the California Department of Justice that oversees elder abuse, to wonder why we keep using them and whether, in fact, the use of these drugs may constitute assault. So there are legal cases in which the argument is that the use of the antipsychotic was, in fact, assault. I'm not saying that antipsychotics should not be used at all. However, there are clearly numbers of cases of abuse. I'm going to give you some more bad news before I stop in 2 minutes, and that is, it took us some 30 years before we actually did clinical trials to look at efficacy of antipsychotics. We've only recently begun to look at the efficacy of antidepressants for treating either depression within Alzheimer's disease or agitation. This is the unexpected result from one large trial of sertraline for patients with depression and dementia. And as you can see, there 2 things were happening. One is that the depression improved remarkably over time, and the other was it really didn't matter whether you were on sertraline or placebo. It improved about as much as on either. And aside from that, after about 16 weeks, 50% of patients in either group were better. And then a similar British study of sertraline and Remeron, mirtazapine, showing about the same thing. Substantial improvement over 12 weeks and no difference between the drugs. The studies are almost mirror images of each other. However, there was a price to pay in adverse events, in confusion, in cognitive worsening, in neurological side effects, and in gastrointestinal side effects. So this is, in the last minute, led to the ideas that perhaps cholinesterase inhibitors can be used to treat behavior. I gave you one case at the beginning that I hope you remember. Our British colleagues, though, have challenged these assertions in a trial in which Donepezil was used instead of an antipsychotic to try to treat behavior, and you see the results, and I'll skip over that. And similarly, memantine, was used by an overlapping group of British colleagues to do about the same thing. We have a patient who's agitated. We do not want to use antipsychotics or anti-dementia drugs. We believe that memantine might be effective. After all, that's what some of the advertising says. So let's do a randomized trial. And I think you see here, again, the unfortunate and frustrating results that the memantine doesn't really improve patients with that level of agitation compared to placebo. But you also see that there is improvement in both groups over time. So, going over my time by about a minute, I'll just telegraph to you that we tend to be drug-oriented, we tend to reach for drugs. There are numbers of non-drug approaches, some of them that don't take very much time, that have more evidence for positive efficacy and effects than drugs do. So here is my summary. You've probably read it before, but the whole point here is that we should not be using the same ineffective treatments we've been doing for some 50, 60 years. We can think a little bit better about this. We can use the antipsychotics when we need them over short periods of time and assessing response, and in general, we can do better. So with that, I'll stop. Sorry to have depressed you too much this morning, but thanks for your attention. Yeah.
So we have time for a couple questions. Linda in the back.
Yes, I've had prostate cancer now for about 13 years. And I've been given a lot of various drugs, and I'm still looking for a cure for the cure for the cure, because you knock out your testosterone and so forth. So maybe I should just stick to walking every day and looking at my Mediterranean type of a intake of good things, and forget about the drugs. What do you think?
So number one, I'm sorry to hear about your condition. Number two, this talk was not about you. This is about treatment of people with mainly Alzheimer's disease and dementia who have these kinds of symptoms. And I think diagnosis matters. So I'm not about to suggest anything for you personally without examination and synthesis.
On the right hand side here.
Excellent talk, and I wanted to ask your thoughts on what do you think are the mechanisms of death with antipsychotics?
So that's a great question, what the mechanisms are. And the short answer is we don't know. The probabilistic answer is several. Various cardiovascular mechanisms, the direct effect of different antipsychotics on electrical conduction, congestive heart failure, cerebrovascular events, and stroke are associated with death. And in the nursing home groups of patients, sepsis was. Urinary tract infection and sepsis were imminent causes, or imminently associated with death. So there also may be sedation that contributes to the debilitation of a vulnerable person who then dies.
Mom, one more question back there.
Yeah. Thank you. I'm a family physician. I think of multiple patients in my practice right now, and truthfully, we're not treating the patient, we're treating the family. We've got families who don't have the financial resources to provide for the patient. They can't afford the nursing home. The mom doesn't want to be in the nursing home, and the patient's agitated and aggressive. They don't worry about mom dying from a side effect. Mom dying would be a blessing to them if she would quietly pass away. They worry about safety in the home, and frankly, it's depressing to hear there's not a damn thing I can do for this patient. And so, you know, and that's because there's no resources in the community for these people. And so is there anything I can offer these people to help them get through the night so that they can sleep and take care of mom in the morning? Because mom's awake all night. I know we'll do sleep issues, but these are the issues we're stuck with in the real world.
So yeah, I agree. First, take the point about the profound lack of resources that many patients have, so that the medical system is, or the medical and social system is almost structured that they'll pay for a 10-minute physician appointment. It will pay for that, but it won't pay for social work, non-medical interventions, and a number of things that conceptually and practically could be done with many of those patients, making home visits, structuring, giving the family some behavioral techniques to deal with the patient a little bit better. And then, as I said a few times, but again, the overwhelming negative message overrides this, is that the drugs are useful for short periods of time in some people, and they may have to be used. And we experience some effects, just like Galen did, we experience some effects, but you can also then try to discontinue and start something else. However, I mean, this is a hugely frustrating problem that you have and that we have. We see this every day as well in our Alzheimer's Center. So.
I think we have
Sure.
one. Thank you.